All right, we are back again with Fresh Air with Sanjay, Matt, and Irene. Now, Irene has become like a regular on our show. On our
Yeah.
show, it's her show too. So, Dr. Sansano is from Barcelona, Spain. She's a pulmonary pathologist. Dr. Matt Cecchini is from Toronto, Ontario.
London,
Matt,
Ontario.
what's the name of the, not Toronto, sorry, Ontario, Canada, I meant to say.
Yeah. I'm from London. I work in
London,
London.
Ontario.
It's like 2 hours away from Toronto.
Yes, yes.
And fun fact, we even have the Thames River as well in London, Ontario. So
You
it's
do? Oh,
yeah, we
wow. You
do.
have a Big Ben?
No, but down the road is Paris, Ontario as well. So we
Oh,
also have we have London, Paris. It's quite lovely.
They run out of names when
Yeah.
they got to Ontario.
I think so.
fun fact, Dr. Cecchini lives close to Niagara Falls. So if you're ever
Mhm.
making a visit,
I do. That's where I was born, like in Niagara Falls. So it's my hometown. Yeah.
All right. So we are going to talk today about like the whole thing is going to be centered around UIP or usual interstitial pneumonia, and we are going to bring up the usual questions that come up around this topic. So we are going to first talk about a very interesting question that was brought up by a pathologist on Twitter, and they asked, "How do you tell the difference between organizing pneumonia and UIP?" That's a very good question because one of the histologic findings in UIP is the so-called fibroblast focus, which is very similar to a histologic finding in organizing pneumonia, which is called the fibroblast plug, or as both Irene and Matt like to call it, the Masson body, which is the sort of um, older name for this thing, but probably a less confusing name than to call it a fibroblast plug. And then those two things look very similar, so people are often confused. Even pulmonary pathologists sometimes find this issue difficult. So we're going to talk about OP versus UIP. So in this particular, Matt and Irene, do you see the pictures clearly at low
Yeah.
mag?
Agree.
You do, okay. So on this picture, the one on the left-hand side is organizing pneumonia. The one on the right-hand side is UIP. I'm going to now just say UIP, but after saying that UIP stands for usual interstitial pneumonia.
Maybe we should just point out that how that corresponds with IPF and what that means, because I think
Yes.
that can often
So
be confusing.
correct. So UIP is a pathologic diagnosis of UIP is mandatory for, or a radiologic diagnosis of UIP is mandatory um, for a clinical diagnosis of IPF. In other words, once you're making a diagnosis of idiopathic pulmonary fibrosis clinically, you need either the pathologist or the radiologist to say, this is UIP, and then you can add to that your judgment that the case is idiopathic and then label the case idiopathic pulmonary fibrosis. Organizing pneumonia is also a essential component of a clinically defined entity called cryptogenic organizing pneumonia. We've talked about this before in this show. And then a cryptogenic organizing pneumonia is called COP by clinicians. So both of them are kind of essential sort of defining pathologic bases for clinical entities. But the interesting thing is, although the one histologic finding in them is similar, sort of similar, the clinical behavior is opposite. So UIP is a very badly behaving entity. It progresses, over years to even more significant fibrosis, and then eventually to death. At least in the past decade or so, the median survival has hovered between 3 to 5 years. So it's really, really bad entity. On the other hand, organizing pneumonia, of course, it depends on the context, but many cases of organizing pneumonia are steroid responsive and potentially reversible. And so it's like the polar opposite of UIP. So it's very important to be able to tell these two things apart. So let me start at low mag. What can you possibly tell at low mag? Well, one thing about this, what that I see at low mag is, so I'm going to use your annotation tip here now, Matt. But low mag, okay, you see it, right? The thing I'm circling. So you already can see many features in this UIP case. What I'm circling here is a traction bronchiectasis. So bronchus that's pulled apart, just a normal bronchus with a partner artery, which is pulled apart by fibrosis in this case. And of course, even at low mag, you can see there's a ton of fibrosis here. In fact, the fibrosis I'm circling now is distorting lung architecture. So that's a scar. Architectural distortion or scarring, that area is called. It's a mass of collagen that's distorting the architecture. It doesn't just keep the architecture intact like you would be in NSIP. And then right next to it, you've got a almost completely normal lung right here. So this thing is called, in the old days, we called it spatial heterogeneity. Some people still like to call it like that, spatial heterogeneity. One is completely abnormal and one is normal. Or you can call it patchwork pattern. That's what Dr. Katzenstein used to like to call it. Patchwork pattern, meaning like the patchwork of a quilt. You put an abnormal area next to a normal area and then it looks like this. Very heterogeneous, very counterintuitive to what you think a diffuse interstitial lung disease should look like. You think a diffuse disease should be diffuse at microscopy too, but it's not diffuse. It's actually quite patchy. So even at low mag, you kind of get a sense that this thing might turn out to be UIP, and that's very helpful, I find. Very helpful that you know, even at low mag, that you're not dealing with a, pure fibroblastic process. You are dealing with also honeycombing, which I'm circling now, which I'm sure we'll talk about in detail in a separate issue, because honeycombing is really one of the most controversial points of UIP. So at low mag, I'm already thinking of UIP here because of the patchwork pattern, the scarring, and the honeycomb change. Even before I get to the fibroblast foci, I'm thinking about that. Guys, anything about the left-hand side that you see that is particularly useful? The organizing pneumonia case?
I guess I would just point out that there also is a localized abnormality, but the abnormality itself appears more temporally uniform, right? In that it appears
like here, right? This abnormality. And there might even be some abnormality there, but we'll see at higher mag whether that turns out to be true. But superficially, you could say this also has a patchwork pattern in the sense there's some normal lung and some involved lung, but the involved lung is not fibrotic, at least to my eye. It's not just a mass of a scar. There's no honeycomb change. And I think newcomers to lung pathology struggle with this idea, that what is patchy and what is patchy enough to be called UIP. All right, let's go to higher mag and see if we can. So do I need to undo the annotate? Okay.
I can clear them. There you go. They should be.
So now let's go to the high mag and go to this so-called fibroblast plug and the fibroblast focus. All right, so let's see. We'll pick out a focus here. Do you guys see the focus clearly? Matt and Irene?
I do, yeah.
Yes, I do.
So this is the so-called fibroblast focus of UIP. Let you guys talk about it, and I'll add what I can after.
Yeah.
Go ahead.
Go for it.
No, you go for it.
The fibroblastic foci normally is dome-shaped. It looks a little bit maybe two domes, but it's dome-shaped and it's in the interstitium. The mason body or the fibroblastic plaque has normally like it has strictures. And in my opinion, it's like dancing or going for
yeah, I like it. Yeah,
going through the cone pores and doing like a dance. I also tell it to the residents, like if you poured something that is like liquid inside and it not liquid, sorry, like what the candles are made of.
Wax.
Like wax inside a sponge, and then you cut it, and it's what you got with.
Yeah. The character of the plug itself.
The shapes. It's more fun. The shapes are more funny, more variegated than in fibroblastic foci.
That's a great description. So here, let me just outline it. Matt, do you want to add anything to that, the plug versus focus idea?
No, I love that, the dancing of that. I often think of them as like more like serpiginous, that they're kind of going through like the one airspace and kind of snaking their way into the adjacent airspace. I was just going to say, Sanjay, if you wanted to match up the two slides, you can click this button I circled at the top there, to unlink them for a second.
Yeah.
You just have to take off your
I
annotation.
think this annotate does
So just take off your annotation and then sorry, just click that button for a second to then
click the button.
Yeah, so then they're now you can move them independently. So if you wanted to match up
Oh, I see. Yeah. So let me see if I can bring up a better focus of the fibroblast plugs than that one. Maybe here. Let's stick with this. Actually, let me keep the bronchiole here. Keep this at about. So we are at about 4x here,
Okay.
and then I'm going to keep it at about 4x even here.
There you go.
Okay, now we have the exact same magnification on both sides.
And now you can link them again if you like.
And then link it back with this guy?
Yeah, yeah.
Manual synchronized, okay.
Okay, and then they will.
Yeah, that's great. So now we see them at low magnification. So one thing I'll add, there's a great paper by Dr. Katzenstein in the American Journal of Surgical Pathology, very old paper. It's like maybe from 1990, maybe even from the 80s. And that specifically talks about BOOP versus or organized pneumonia versus UIP. And that's what the paper was meant to do, that is to list all the differences between organizing pneumonia and UIP because of this exact reason. And one of the things that points out is that at low magnification, that the fibroblast plugs of organizing pneumonia tend to be clustered. There tend to be many of them together. And so let me just use the annotation. I think that's one thing that people don't know enough. And I think it's very helpful, again, at low magnification, even before going to the interstitial versus airspace thing. You can see that the bronchiole, here's the bronchovascular bundle, that these plugs are all clustered in the air spaces around the bronchovascular bundle. And this correlates actually very nicely with the imaging, where they typically say there's an airway in the middle, and then around the airway there's a sort of dense rim of consolidation or ground glass opacities. And that, of course, they're not talking about airways of this size, but this is the microscopic correlate of that at a more fine level, is that you typically have an airway in the middle and then clusters of these fibroblast plugs around that. So I think that's a very helpful low mag feature for this. Now, let me just see in the UIP thing now you don't see exactly the same thing on UIP, because in UIP, although occasionally you can have fibroblast foci that are more florid, they tend to be more spaced apart. There's one here, then one there, and that's one feature that's helpful to tell a fibroblast focus from a fibroblast plug. Let me see what else is useful. Another thing that's useful is when you look at a fibroblast focus, like on the right hand side, a fibroblast focus is made mostly of fibroblasts, not of inflammatory cells. So let me just again go back to the draw thing.
It just
less inflamed.
Less inflamed. In fact, almost no inflammation. It's all fibroblasts in a kind of myxoid background. Now, when you go to the fibroblast plugs, I feel that there's a lot more inflammation there, in the sense that sometimes the plugs actually contain plasma cells, lymphocytes, histiocytes inside the plug. Here we go. See, like this is a fibroblast plug, and you can actually see that there are a few plasma cells inside the plug. And I think that's very, very helpful, is that you almost never see an inflamed fibroblast focus, whereas it's very common to see inflamed fibroblast plugs or Masson bodies. And then we come to the airspace versus interstitial thing, and that's where I think the confusion starts, because although that is true, if you look very closely at a fibroblast plug, you can almost never tell that it's purely airspace.
Yeah.
You can convince yourself that is in the interstitium and that the space next to it is the airspace. So I think that is, you almost have to infer airspace location by the shape of the thing rather than by actually looking at the interstitium. And that's, I think, what's happening here is that the fibroblast plug is actually arising from the interstitium and then snaking into the airspace. So if you look at the plug itself, it looks like it has type 2 pneumocytes on the surface of the plug, but that's because it started from the interstitium. And I find that if you, as a trainee,
or hiding, maybe it goes out from the interstitium, or it's hiding in the interstitium.
In the interstitium. So I want both of you to, Irene and Matt, tell me your thoughts about that, the airspace versus interstitium thing. How do you approach that?
I guess to me, a big thing, as you said, is the shape of it, because I find it really challenging to say, oh, is there an epithelium over top of it? And I find that often tricks me. And so to me, it's really the shape of these plugs, and that if they look like they're conforming to the contours of these air spaces rather than pushing and causing this kind of bulge into the overlying space, that I find that is the most useful thing to sorting it out.
How often do you find this challenging, Irene? Like, is it easy for you to tell plugs from foci, or is it hard? And what do you use to tell it apart?
I find for me it's hard because working with cryobiopsies, the pieces that you have are so small. The one you are showing there, the UIP one, would cause trouble also to me, because there are too many fibroblastic foci, but as you can see, the whole thing with the honeycomb, the patch, it helps a lot. But with cryobiopsies, that's my main substrate. It's
yeah. Let me show you a more classic one. Maybe I didn't show the best one, Irene, on the fibroblast foci. So if you saw one like this, that wouldn't be a problem, right?
No problem.
Yes, yes. So I think sometimes it's so easy to tell because there's a layer of epithelial cells over it, and then there's mucin in the air spaces, so you know exactly where the interstitium and the air spaces are. I think in UIP it's actually easier to tell where the interstitium and air space is. In OP it's harder to tell what exactly is airspace and what is interstitium.
Yeah.
But if you had a fibroblast plug like this one, I don't think anybody would find it difficult, right? I mean, this is classic. Just like you said, Irene, dome shaped on one side, and then no inflammatory cells, and purely in the interstitium.
I think an important point too is that the cells in these plugs or foci are actually very similar, right? These kind of loose, kind of fibroblast cells in this kind of mucopolysaccharide rich background can look very similar in both. And so I find the cells that are in there not really helpful in discriminating between the two.
Yes, they look identical, I think.
Yeah.
And especially this sort of myxoidy background. Like if you learn that everything that has fibroblasts and is myxoid is a fibroblast focus, then you can very easily go wrong, because if you see your first organizing pneumonia case, you'll think, oh, there it is, and then you'll call that UIP, and that's a kind of trap to be.
Yeah, and I think the term too can be misleading, right? Because the term is just foci of fibroblasts, right? Fibroblastic focus, right? And that conceptually that very much fits with a plug in UIP in OP as well, right? Like that is a focus of fibroblasts, right? And so from a learner's point of view, it's not uncommon to say, oh, there's the fibroblastic foci, right?
Yes. Yeah, absolutely. I think you're right. You're spot on about that. Is that it's confusing? The terminology makes it difficult for newcomers to easily learn this. I think that's very much true. Here
maybe fibroblastic foci. We complained about fibroblastic plaque, but maybe fibroblastic plaque is a good name, and the bad name is fibroblastic foci.
Yeah, maybe that needs a
it's not so descriptive of, maybe we should call it fibroblastic domes or something like that.
Yeah, but I think is there anything that we have? Okay, let me ask you guys this question. If you are struggling on the pathology, do you ever then go back to the radiology and say, I can't tell UIP from OP here, but maybe the imaging will help me?
Never in a surgical biopsy, but maybe in a really small cryobiopsy or transbronchial biopsy, I would say.
Yeah, this is tricky. Irene, what do you do? If your question is OP versus UIP, do you go back to the imaging and use it?
I use it I make my decision, but I'm happy if then the radiologist says, oh, look, this condensation here or so.
Yes.
It makes me happy, but I won't change what I said.
You know, Matt,
there are problems.
Go ahead.
Sometimes I have you have this organizing pneumonia, and I said I'm sure it's organizing pneumonia, but there are at some point there is a scar, and I put it in the micro description. I think I see like 1, 2, 3 fibroblastic foci. Then they say we are going to control this because you said there are fibroblastic foci. This is the problem, that sometimes I'm sure why we cannot have a pneumonia on top of a UIP. We see that.
Yes, that's exactly the point I was getting to, Irene, that you have absolutely hit it on the head, is that when you get UIP with superimposed organizing pneumonia, not uncommon, right? It's very common to have superimposed DAD, acute lung injury, organizing pneumonia. That's where you can go wrong, is if you say that because the radiology looks like it's all consolidated, that there can't be an ILD under it, or because the radiology looks like it's UIP, there can't be an OP on top of it.
Yeah, I agree.
I think both are wrong. You can go wrong on both ways. So I feel that that's like a tricky thing, to use the radiology to guide a pathologic decision is difficult. You know, it's not at all straightforward.
No, I agree with you completely. And it's but I guess there's always a role for trying to put all the pieces of the puzzle together, right? That you know, if this is a patient that has radiologic features of UIP, you know, and you're questioning that there's some interstitial component, then that might be helpful, right? But you know,
I agree. Like, I'll give you an example, Matt. Let's say somebody has a right lower lobe consolidation, right? They have a pneumonia that didn't go away. They have a right lower lobe consolidation. I get a small transbronchial biopsy from that, and I'm thinking, is this a focus or a plug?
Yeah.
Then I go and look at the radiology, and all there is a solitary unilateral. Yeah. I go, no, that's not UIP.
Exactly.
You know, and I don't have to worry about UIP.
Exactly.
That's true. In that, so there are. I guess it really depends on the specific question and the specific imaging, how you use the.
Exactly, completely. Whereas if the patient was someone who said query UIP, you know, then you might, you know, be a bit more descriptive, and you're not going to outright call it UIP, but you might raise that as, you know, it's a bit challenging to tell where these are.
Yes. But I've seen the opposite too. You know, I've seen, you know, you can misuse the imaging too.
It's
so
true.
Let's say something looks like UIP, then the imaging says, well, you know, it's a more upper lobe, or it's looking like NSIP. You can transform your fibroblast foci into acute lung injury, and you know, it becomes foci of organizing acute lung injury, and you've basically diluted the value of the biopsy in that case, you know, by too heavily swayed by the imaging. So I think it can go both ways. It's a very tricky issue. Yeah. Okay. I think we've pretty much addressed. Any other things you guys want to add for UIP versus OP?
I think it's a great discussion. Maybe I can show a case next, if that's okay.
Yeah, that's great.
Okay. Okay. So can you guys see that there?
Yeah. Perfect.
Okay. So this is something sometimes I struggle with, in that you get these larger surgical wedge biopsies where the whole thing is abnormal, right? And that there's really not any normal lung left, and so you can't really, that patchwork pattern of it is not really here anymore, in that at this low power magnification, it all kind of looks the same, right? This dense fibroblasts, this dense fibrosis, and I think at low power you can actually see there's many fibroblastic foci, kind of this looser look to it.
Yeah.
So you have that aspect of it, but you're really lacking the normal looking lung, right? And in this degree of involvement, it's difficult to see the distribution of it as well. So I can't tell if it's more centered around subpleura, or I can't tell if it's more central lobular focused. And so
yeah,
it's really just quite dense. But I think if you go into a little bit higher power. I
You
think
can see some of the foci even at low mag.
I know, yeah.
It's kind of pop out. It's
Yeah,
beautiful.
yeah. This case has really nice examples of them. Where I think just as a review, here are these nice fibroblastic foci. They kind of bulge into the airspace here, and I actually like the spatial and temporal heterogeneity. I like to think of it as the past, present, and future, where the past is this dense fibrosis that's long gone and all fibrotic, and the future is these fibroblastic foci that are kind of the leading edge of these fibrosis. And I like to think of them as factories that are driving these ongoing fibrosis. There's literature that suggests that these are actually making a lot of the metalloproteases and things like that that drive the fibrosis. And then the future is the uninvolved lung. And so I guess the challenge in this one is that you have this past, this dense fibrosis, and you have the present, these very prominent fibroblastic foci, but you're lacking the future, the uninvolved lung. And so I'd love to hear what you guys think of cases like this, where you have really just dense fibrosis without really uninvolved lung.
Irene?
When I have only honeycomb, I say honeycomb just, but I would doubt in this case because you have many fibroblastic foci, then maybe you can go for UIP. And normally I want to see normal lung to say UIP.
Yes.
What would happen if I saw the lung and the lung was not abnormal? I mean, you see now next to it, inflamed lung, imagine, pneumonitis. Yeah. I think it depends on your approach to say UIP or not to say UIP in this case, because what is happening to this patient is bad. He has a lot of fibroblastic foci, he has the honeycomb, then it's whatever it's the cause of this, it's going to go bad. Then this is the important thing, to transmit this.
Yes, I do the same. So I'm exactly what Irene is saying is essentially when you have a lung that is this bad, this degree of honeycombing, scarring, fibroblast foci, there is, in my mind, there's essentially only one diagnosis here. But I see your point too, Matt, that this does not meet criteria in the sense that it does not have them. So in practice, I would call this honeycomb change, but in the comment, I would say that this is most likely UIP, or the things with all these features most likely represent UIP, and that the only feature that's missing in this biopsy is normal lung. And then, people would ask, well, what else could it be? Yeah. Right. And to me, this is way too much architectural distortion for NSIP, right? That this is just doesn't happen this much. And then you get into the more controversial stuff, right? Then people will say, how do you know this is not chronic HP or PPFE and all that stuff? And again, I just, in practice, that's extraordinarily uncommon for a thing like this to turn out to be either one of those. So it's a very good question because it shows you
depends on
features that are almost there. What do you do?
It depends on your practice. I mean, if you work in a hospital that are so prone to say chronic HP, you can find an antigen or so. But what I wanted to say is that I don't mind what's causing this. You have to transmit that the biopsy is very bad. In this case, if it's chronic HP, is going to the patient is going to need I don't know, transplant or whatever. Right. Exactly right. And again, this is a point that people have said for decades. I mean, we are not the first people to come up with this idea. Is that when something is UIP, it behaves bad regardless of what the so-called presumed etiology is, right? So connective tissue disease with UIP, people have been doing studies for decades on those things over and over to try and show that connective tissue UIP is different than regular UIP, but those patients do very badly. With scleroderma UIP or rheumatoid arthritis UIP, if people with asbestosis and UIP, chronic HP and UIP, once you get to this stage, I mean, it's exactly what Irene is saying. It's likely to be progressive disease, unresponsive to corticosteroids, likely to,
come to either transplant or progressive disease and death. So how I see it is not as an etiology. I mean, I keep on hearing clinicians say that it's so important to tell the etiology. Well, what is the importance to tell the etiology when somebody has end-stage lung disease like this? You can't reverse the etiology. But I feel it's more important to determine whether this is reversible disease or not. I think that's the more important question. Is this something that will be reversible with corticosteroids or immunomodulators, or is this something that is at the end and now needs either antifibrotics or transplant?
I agree completely. I just left it on this area here because we've said the term honeycomb change a bunch, and I thought it might be useful to talk about what is honeycomb change and how we differentiate that from other areas. So
great topic. We can be like here for 3 days talking about honeycomb change. I want to hear what you guys how you guys do it. Can get either one of you?
Well, the complete lobule disappears. I see we see the septum more or less and the pleura, and the complete lobule disappears, and all the airspace turns into little cysts covered by bronchial epithelia.
Yes. So Irene, can I ask you? Can I be the interrogator and ask you some questions? Like I'll be the student, okay, and you answer me. So I say, Dr. Sansano, where does these cells come from? Like where do they? How come you have these ciliated cells in the alveoli? Where are they coming from?
You are trying to lead me. Okay, I imagine that come from the airway, the central airway.
The airways.
I imagine that appear from there, like.
But all the books say that UIP is not an airway-centered process. That it comes from the pleura and the interlobular septa. I don't understand that.
What I say to my residents, I don't have an answer for that. Like, you can write a book on bronchial metaplasia versus honeycomb, and.
So can I ask you that question? So what is the difference between peribrochular metaplasia and honeycomb change?
For me, the spaces in bronchial metaplasia are not closed, are open. It's covered like lambertosis. It's around the bronchioli, and are not closed, and it's clustered, as you said. When the whole lobule have disappeared, like here, it's a honeycomb.
I see. So by open and closed, you mean that on one side of it is normal alveoli? That's what open means?
Yes, that it has not three. Yes.
And what we're seeing here is closed, like means there's nothing on the other side of it. That's what you mean by open and closed.
That it's not slightly transitioning into lung, normal lung.
I see. Okay, Matt, how do you do it? So what can you answer the same questions I asked Irene? So first of all, where do these cells come from?
I guess I think of them as a metaplasia, that you get these cystically dilated spaces that get accumulation of this central mucinous material, and the lung's response to that is you get a metaplasia that can sometimes be bronchial or sometimes can be squamous, and you often see these different metaplasias that occur in these cystic spaces, and I think of it as a reactive type of process.
Where do they come from, these cells? Where do you think they come from?
I think they're pneumocytes that become metaplastic,
Oh, I see. So it's not really coming from the airways. It's just that pneumocytes are turning into.
That, yeah, but how do you prove that? You have to do like lineage tracking on these cells, right? I don't think you could ever prove that. But
so can I ask you? So in this picture that you have shown here, at the top of the picture is an artery, right?
Mm-hmm.
That's correct. Yeah.
So there must be a bronchiole next to it.
Let's see.
There is.
Maybe even the central, the one to the below and right of it might be the partner bronchiole.
The one that has the muscle around.
That has the muscle.
Yeah, that one there that I highlighted. Right. Yeah.
But you're telling me that all the rest of it is honeycomb change, correct?
Yeah. So This to me is honeycomb change.
Honeycomb change. So then this whole thing is peribronchial.
Yeah, you're right. Okay, so maybe these cells extend along it, but you know,
Or are pluripotential cells from the airway or from the next to the pneumocyte?
Yes.
I don't know. It must come from a cell that has this capacity.
Yeah, and of course, none of us know, right? We don't actually see the cell transforming into that, and that is exactly my objection also to this idea. You know, people say it starts from the pleural region and then it goes here, and well, nobody saw that, right? Nobody sees fibrosis going from anywhere to anywhere. What you are assuming is that based on whatever, you know, early forms of UIP and late forms of UIP, you are surmising that that's what must be happening, right? It must be starting there and going out there, but nobody has seen where it starts. But this is really a good discussion to have, right? Because that's what it, in students' minds, this is how it goes. Can I ask both of you one more question? So how do you square the idea of fibrosis, which is a matrix problem, right? It's a too much collagen, turning into an epithelial metaplasia kind of problem? How does that, why does too much fibrosis lead to an epithelial metaplasia? Either one of you.
I don't completely understand. You mean in bronchial metaplasia or?
Yeah, like, or honeycomb change. So, right, so you've got UIP, you're saying fibroblast foci, just like Matt says, fibroblast foci make collagen. Collagen becomes old collagen, then there's more collagen, then more collagen. So you think eventually the whole lung would be all collagen and that would be the end of it, right? Why does it turn into this epithelial problem? Why is there peribronchial metaplasia, honeycomb change? How we were talking about collagen,
Really?
we're suddenly talking about cells.
Really, it makes more sense that the whole thing gets fibrosed, and then the bronchioli says, "I'm going to put parquet in these things." But I don't know.
Matt, do you know? Do you know why this gets involved like this?
Maybe I overthink it, but the way I think of it is these fibroblastic foci make not only collagens, but they also make matrix remodeling proteins, such as metalloproteases, and that has the ability to restructure and reorganize the lung. And that's why you get this architectural distortion that is characteristic of UIP, which the end result is this honeycomb change. And then, like, I think if you look at this area, you see a spectrum of cells lining this, right? That range from these more cuboidal cells all the way up to ciliated cells. And to me, that suggests that you see this gradation in the spectrum of changes. It underlies the fact that it's a reactive process to this architectural distortion. And so I view it as there's something that's driving an architectural stain, whether it's the fibroblastic foci or whatever, that make these things that allow the lung to reorganize. And then once it's reorganized, then the epithelium responds to that. And then you get this reactive change to it. That's how I conceptualize it, but I can't prove that. As
the epithelium responding to distortion that's caused by the fibrosis. That's how I
conceptualize it in my head, but there's no experimental evidence that proves this, at least that I'm aware of.
How do you, so the same question I asked to Irene, how do you differentiate between peribronchial metaplasia and honeycombing?
To me, it's the architectural distortion, right? And so we've lost the normal alveolar architecture here, and we have these cystically dilated spaces with intervening fibrosis that stack on top of each other. And one of my radiologist colleagues always says, how do they know what honeycomb changes on imaging? Is that it's a space that's big enough for a bee to crawl into.
But what would a bee?
Like a bee, like a buzz's bee, like you can imagine like a little bee setting up a home in each one of these little honeycomb spaces. Whereas, you know, I think if you're looking at an alveolar space, that would be too small for a bee to get into, right? So, you know. So when I see these spaces with fibrosis that stack on top of each other that I can imagine a bee getting into, I think it's honeycomb change.
I see. So would you, again, another question to both of you, would you diagnose honeycomb change with if it has exactly the same look but no fibrosis in the background?
I can can't imagine this. I mean, the normal alveoli shape and with the size,
right. Normal alveoli, and then this stuff in the this stuff on top of it.
I would say it's.
Would you call that honeycombing?
I don't think so.
I think the one time it gets somewhat confusing is when you have bad emphysematous changes, and then you get some bronchial metaplasia that lines areas of emphysema. I think that maybe could be a case that you're describing, Sanjay, is where you wouldn't expect to see lots of fibrosis, but you still could see some bronchial epithelium. And then is that honeycomb or is that just emphysema? I sometimes struggle with that.
Do you call honeycombing even when there's no honeycombing on the CT?
Yes.
What about Irene, you?
That's what I was going to say. What if the radiologist says here, no, it's NSIP. This is the lingula. I would say, well, I don't see the rest. I see here honeycomb.
Should we do it now, Matt, instead of the next one? So this question about radiologic NSIP and.
Yeah. So I just put a measurement there. I'd say that this is less than a millimeter in size, right? And that's probably might be below the resolution of what they can see on imaging. And so, sorry, you can describe your thing, but to me, I would say this is microscopic honeycombing.
What is what they call honeycomb? Because it's not this. This is sure. They see honeycomb. The holes that they show in the CT that we can see in the CT are not these holes. These holes are 1 millimeter. What are?
Because their holes are much bigger, Irene. Like because they can only see, more than 1 or 2 millimeters in size holes.
Then where is in this biopsy what they see, or they were not seeing?
Probably not. Probably none of this. What's in the biopsies? Which actually brings us to a very interesting point. That we talk about radiologic pathologic correlation, but in fact, there is no radiologic pathologic correlation.
No,
what they are seeing is very macroscopic things, and we are seeing microscopic things, and they don't correlate. In fact, what they are, stuff like this probably looks like reticulation to them without any specific features,
Or maybe all this lobule, the whole thing, it's a hole in the CT. Looks like a hole.
The whole thing is a hole. I don't know, Irene. Like I'm not sure
the whole lobule. I mean, all these spaces with the artery and the bronchial.
I'm not sure they would even see this. I at least, and again, it's impossible to tell without actually correlating one particular focus specifically. But my guess is that they would see this whole thing as a
reticulation,
white blur instead of a hole. That's my guess. Because it's below the resolution of what they can see as a same thing. For example, I'll ask you, the bronchioles we see are very small, right? The bronchioles we see on histology, most of them are invisible on CT because they are too small. So when you see a bronchiole, what do they see on CT? Do they see a hole, or do they just see a white blur, or do they see just normal lung? It's impossible to tell because it's below the resolution of the CT scan. They can't see that. They cannot see a structure that's so small, which is, I've been told that that's about 1 to 2 millimeters. Anything less than 1 to 2 millimeters cannot be seen on a high resolution CT scan.
So they might see things like this, which is approaching 2 millimeters.
Yeah, if you're slightly above a millimeter, they might see a hole there.
And I'm reporting this meningothelial nodule, so I have a 1 millimeter meningothelial. Nobody sees that.
Impossible to see. I mean, how will you correlate something that you cannot see on a CT scan? And that basically applies to every microscopic finding, right? Almost everything we see is less than a millimeter in size, so it doesn't correlate with theirs. Something has to be really big, like a fairly big cyst, or a big mass, or a 1 centimeter ground glass opacity to even show up on a CT scan. For example, let me ask you both. What is the CT correlate of a fibroblast focus? Nothing.
For sure.
They can't see it.
But for example, in alveolar microlithosis, the calcospheristes are very, very tiny, and they see it like a sandstorm or something.
Correct. But Irene, are they seeing in those cases, like for example, in sarcoidosis also, just to give you another example, granulomas are very small, but they see them, right? But I don't think that what they're seeing is an individual granuloma. They're
No.
seeing a confluence of many granulomas.
That's why I was thinking that they saw the whole thing as a whole. All these tiny holes, a lot of them, and they see
it as one whole. It's possible. I'm not sure. I
not
really
sure.
don't know what they would see it as, but I'm pretty sure that they don't see what we see. You know, like what looks like honeycomb change to us at this level is whatever they see, whether they see a hole or a gray image or a reticulation, whichever one of them it is, it's not the same as what we see. It's not in other words, it's not a one-to-one correlation like the textbooks say it. And what they're really missing is that almost everything we see is below the resolution of what a CT sees.
Yep. I think it's a great discussion.
This is a great discussion to have because that gets to the point of why would you need pathology in a case where radiology doesn't see honeycombing? You need it for exactly this reason. You need it because there are some cases where they cannot see honeycombing and where we can clearly see honeycombing. So that's clearly UIP for us, but NSIP for them. And then there's a lot of literature to back that up.
And that's why we shouldn't change our diagnosis, no matter what they say, because they are doing the biopsy for that.
Yes, that's exactly right. And that brings us to one very kind of interesting sort of vicious cycle that happens, is that let's say you're a pathologist that doesn't know this, right? Let's say you don't know this, and you have heard at a conference, radiologic correlation is very essential for lung pathology because it's very, very important to look at the CT. You go, of course, yes. Then you look at the case and you're like, I don't know if this is honeycombing or not. This is my first UIP case. I don't know. Let me see what the radiologist called it.
Mm-hmm.
So you go and open your thing and you go, does not meet ATS-CRS criteria, no honeycombing seen, favor NSIP, right? On the CT, and you go, well, this must be what NSIP looks like. Then my thing is NSIP. Now clinically, that's actually, it works, because you are in sync with your radiologist. The clinician is in sync with the radiologist. They can see what the radiologist is showing them, that there's no honeycombing. So in politically and clinically, it works really well to call this NSIP, but it's wrong,
Agree.
And it actually politically, it gets you into more trouble to call it what it really is, which is UIP. Because then you have to fight. You have to fight with the imaging person. You have to explain all this stuff. You have to talk about the limits of resolution of a high resolution CT scan. It's much easier to call it NSIP and get it over with. But that's the wrong thing for the patient. So, and how do we know that these are really UIP? There's a great paper from the Mayo Clinic with Dr. Colby and Leslie and all these guys on it. Gruden is the first author of that. They actually looked at cases exactly like that, where they look like NSIP on CT, right? But the pathologist called it UIP. And how did they behave? What do you think?
Like UIP.
I mean, we know the answer to that, right? So there is literature to back that up, but it's amazing how often this happens, that the radiologist actually drives the pathologic diagnosis.
I think that there is a misconception in. I think it's important to correlate and to make for the whole entity. I mean, to say that things are idiopathic, or to say to put the big name to the thing, but you should not correlate your biopsy. If they are seeing NSIP and you're seeing UIP, this has to have another name, and we can arrive to that. But the biopsy is going to be UIP.
Yes. Can I give you another analogy? Because they're going to be residents and other people listening. Let me give you another analogy to that. Okay. You go. Let's say you're in a lab and you're reading a hemoglobin level. Okay. And you say the hemoglobin is 7. Why do you say the hemoglobin is 7? Well, I did this test and that happened and the level was that. And you have your technical reasons for calling it 7, right? And then the clinician says, but this guy, I looked at his, I looked at the eyes and they're not, they don't have the pallor that we typically see in anemia. Now, there are two approaches as a pathologist you can have. You can say, well, the hemoglobin is still 7. Right? So, of course, we need clinical correlation. You can say, well, because there's not pallor, he's not severely anemic to the point that he got pallor in his eye, maybe then you have to look at the peripheral smears. Is this leukemia? Is this megaloblastic anemia? Is this iron deficiency? Of course, you need to do that. But the hemoglobin is still 7. Now, you can have another approach. You can say, I'll be the kind of pathologist who looks at the clinical picture first. So you go and see, is there pallor in the eye? They go, no pallor. Okay, now the hemoglobin is 13. So that's what I don't like people to do. I don't like people to change the fact based on the clinical setting. But I want to hear how you guys do it.
I see your point, but I don't like your example because what we do is not a number, and it's an interpretation, and it's a subjective interpretation. In this case, it's not subjective. In this case, I think it's clear. But as there are so many opinions in non-tumoral lung, it's not like 7. It's not in the microscope. It's not written a number. It's not that easy.
True. No,
I see your point.
You're right, and I see your point too. You're absolutely right.
Okay, can I flip the point for a second? So,
yes.
So what if you have a case where you're not seeing honeycomb change, and it looks more like potentially an early UIP where there's some subpleural fibrosis, but it's kind of minimal, and the sampling's not great. And then you're discussing the case in an MDD round, and you're saying, I'm not sure, this could be UIP, or an early UIP, but I'm not seeing honeycomb change. And then the radiologist says, oh, but I see definite honeycomb change in this area.
Yes.
That might not have been sampled.
Yes.
What about that?
That's a great example, Matt, because this is one setting in which you should give way to the imaging, right? Because they are looking at a lot more lung than you are.
Yeah.
And they are actually identifying a trump card sign. In other words, when you're comparing, let's say, NSIP versus UIP, honeycombing is really the trump card, right?
Yeah.
You're saying if there's enough honeycombing, that is UIP. So in that setting, I would always give way, and I would say, yeah, of course, if you're seeing honeycombing on imaging, go for it. Then that's UIP. In fact, if the honeycombing is big enough to be visible on radiology, it basically cannot be NSIP. So it does really depends on the exact question and the exact findings that you're trying to. It's not just one rule applies to every situation. But what I would say is that I would never change my pathologic interpretation based on the radiologic finding.
Of course.
But I would love to hear what the radiologist sees. I love to hear that. It actually, sometimes it helps, sometimes it doesn't, but it's always helpful to know how the two go together. Irene, you want to say something?
No, I completely agree. I see Matt's point, but I won't change. If I am in doubt, I'm not going to stop being in doubt of the biopsy because the radiologist says there is honeycomb. I agree that the patient should be labeled UIP or IPF in this case, despite my biopsy doesn't say so, but I won't write down UIP because they are seeing that just with a fibroblastic foci.
Yes, and let me make it clear, the point where I'm talking about not looking at the radiology to bias you is specifically this point of UIP versus NSIP. That's where I'm really adamant about it. But let me give you another example where looking at the clinical setting would be very helpful. So let's say you get a pneumothorax case, right? You're seeing a lot of subpleural fibrosis. There's an occasional fibroblast focus, and you're going, oh my God, is this UIP? It's a relatively not that clear cut. There's no honeycombing, but I'm wondering, is this UIP? Then you go to the radiology and you see there's 0 interstitial lung disease. This patient is a 19-year-old with a recurrent pneumothorax, Of course you would back off from that, right? You would back off because you know that you're completely in the wrong setting, So yes, I use the imaging in that situation, but in an imaging of a diffuse bilateral fibrotic interstitial lung disease, where the question is UIP versus NSIP, it's not a good idea to use the radiologic NSIP to bias your diet. That's the specific point I'm trying to make.
I agree completely.
Or saying severe rejection or mild rejection and the patient is not transplant, then I would go back from the diagnosis.
Yep. Do not call it acute cellular rejection if the patient is not a transplant.
Despite there are the lymphocytes around the vessel.
Yes, yes. And as Dr. Katzstein used to say, that, clinical information prevents you from making a foolish diagnosis. Of course it does, yes.
It has happened to me, showing to a resident this beautiful lymphocytic coughing here with the eosinophil, and it's like, oh, okay, it's a beautiful permanent, but it's not the diagnosis.
Yes, but I would also say, actually, let me ask you guys this question. If you, Matt, can I ask one more question?
Sure, go for it.
So let's say you have a perfect UIP, okay? Perfect UIP. Let's say like the one we saw in the first case.
Yeah.
And I tell you, this perfect UIP was in the lower lobes. It's lower lobe predominant. It's a 75-year-old man, ex-smoker. The clinicians think it's IPF. Let me ask both of you, what would your bottom line pathologic diagnosis be?
A usual interstitial pneumonia.
Okay, Irene, yours?
Sorry, I see usual interstitial pneumonia with everything.
Yeah, you see perfect usual interstitial pneumonia. And I tell you the clinical setting is they're suspecting IPF. A patient is 75 years old, ex-smoker, lower lobe, peripheral predominant. What is your pathologic diagnosis?
UIP.
Okay, great. We are all on the same page. Now I'll give you another scenario. It's a perfect UIP. I tell you the patient is a 35-year-old man with upper lobe predominant fibrosis. So there's a ton of fibrosis, but it's upper lobe predominant. Patient is, a never smoker, but what is your pathologic diagnosis now?
Still,
in my case, it's UIP.
Yeah.
Matt, you want to say something else? Matt?
No, still UIP, but I always write a bit of a comment for these, and so I would probably highlight some of those features in the comment, and then to me that's a flag that a 35-year-old with UIP, and so I would be looking for some other cause of what's
like a familial IPF or something like that.
Yeah, something like that, and
pathologic diagnosis is
still UIP though.
Yes.
Just like if you have an adenocarcinoma in a very young person,
yes,
and you say this person has to have a translocation or has to have something.
Yes. So you question yourself, right? You say, "Oh, am I sure that this is UIP?" But if it's UIP, it's still UIP.
Yeah.
Even in a 34-year-old, even if it's upper lobe predominant, even if it's not peripheral predominant. So the point I'm trying to make with this hemoglobin of 7, Irene, is not, I know it's wrong because it's a more objective thing. But the point I'm trying to make is that we are in the position of having a laboratory test that can, sort of functions as a gold standard, even if they don't accept it. But that should not be modified by the, by any kind of clinical information. In other words, you shouldn't be tailoring your diagnosis to what they expect to hear. Yeah. That's the only point I'm trying to make with this thing, And also it's very important for trainees and everybody else to know that IPF is not a pathologic diagnosis. People feel like they feel the pressure to diagnose IPF and it's not a pathologic diagnosis. It's not our job to diagnose IPF. It's completely the clinician's call to accept a case as IPF or not, but it's not our job. But I want to hear both of your thoughts on whether pathologists should be diagnosing IPF or not.
No.
Irene?
No. I was agreeing. Like, no, we shouldn't be saying IPF.
Yeah. I think that we've covered a lot of ground on the UIP stuff with all of this.
I just want to, it was a great discussion. Before we end, I just want to make one quick point that often comes up for junior trainees is that in these areas of honeycomb, you often see all these neutrophils and things like that. And that I often see some junior trainees saying, oh, well, there's a bronchopneumonia on top of the UIP. And so that's just from this obstruction. And one of my mentors used to always call this the sluggish pipe, right? Is that these airways aren't working well anymore. So you get this kind of sluggish flow that accumulates, and you get all these neutrophils and these foaming macrophages, and it's really of no significance.
Yeah. That explains all the bug stains that come from the outside, with the UIP case, AFB, GMS, gram stain, CMV, herpes. Like, why did you do that?
Yeah. But yeah.
Explants sometimes are full of these cells in explants, and you see it like really purulent, the honeycombing.
Yeah, exactly.
Yeah. Well, I think it was a great discussion. Any more last minute points before we end the recording?
What about honeycombing in cryobiopsies?
I don't know, do you want to say that for another week, or do you want to keep recording?
Let's do it since she's brought it up.
Sure, yes.
Quickly, we'll do it quickly. So
sure.
For me, Irene, the short answer is I use the same criteria as I do in any larger biopsy. So it's harder to see because the specimen is smaller and you often miss it, but I use the same criteria.
I find it really hard because I see that you get a level and you see the honeycomb, and then you get another and you see the bronchial there, and you see it's some bad cut of the airway. We can see some examples another day maybe.
Yeah. Maybe when we see a specific example, we can talk about what we would call it in that particular case.
That's great. I think it was a great discussion. Hopefully we cleared up some of the mystery of UIP, which I think.
Yeah, I think, despite the fact that we conceptualize it, many things differently, there's a lot of similarities in how we think about things, right? Like there's a lot of common ground too.
Yes.
Yeah.
Yes.